So we're going to talk today about ADHD in girls and women to some extent. Here's some disclosures. Been funded by NIH for a long time. Charles Schwab Foundation has funded the SFUC Berkeley Schwab Dyslexia and Cognitive Diversity Center that I co-direct, and book royalties from several publishers. What we're going to start off with is a Letterman. Letterman's retired, but we're going to do a top 10 list. Why has it taken so long for everybody to understand that girls and women can and do have ADHD, and what are some of the historical reasons for that? I'm going to talk a little bit about sex, gender differences, but a lot more about our longitudinal prospective study of girls with ADHD and look at some of the developmental pathways, including the crucial developmental psychopathology concept of heterotypic continuity. Behavior A may predict behavior A at the next time point and the next time point, but what if behavior A transmogrifies into a different phenotypic manifestation that still might reflect an underlying vulnerability? I'll close with talking a bit about stigma, which could be a whole other topic and lecture unto itself, but why would people with ADHD receive stigma in this day and age? We know so much more about it, and particularly girls and women. And then I'll have a few concluding slides. So, our top 10 list, number 10, it's not just about girls and women with ADHD. It's not just about coronary artery disease, which was one of the leading guideposts for in 1993 NIH's requirement that girls and women be represented in research, but it's about basic animal research. So a colleague of mine at Cal, now retired, of Zucker, and a student of his, Annalise Beery, who's a professor of integrative biology, over 10 years ago wrote a review, and it's really worth reading, and it's been updated since, and the progress hasn't been what we'd expect. In basic animal physiology research, nothing to do with humans, nothing to do with clinical conditions, diagnoses, dimensions. If I've got it right, 28% of the studies they reviewed had males of the species only as the subjects, 6% had females only, and the remaining large percent had both sexes, but never, except in a few instances, analyzed for interactions of sex and the variables of interest. It's unbelievable, or is it? If you read the New York Times just last month, several commissions have said, you know, we kind of made a mistake in recommending what species and sexes of the species to use in animal research, because the assumption underlying has been that women's puberty and menstrual cycles and parturition and perimenopause and menopause made things so difficult that we thought males were the exemplar species. But you know what? Males have cycles too, and we've made a huge mistake. This took till 2023 for such an admission. So, again, beginning 30 years ago, NIH requirement, first for girls and women in research, now for various ethnic and racial minority groups, children, et cetera, et cetera. We're trying to get broader, but if you read the recent meta-analyses, we're still not far enough, especially with girls and women. Okay, number 9. It's a self-fulfilling prophecy. I learned in grad school a long time ago that girls really didn't have ADHD, that it was about 15 or 20 to 1 boys to girls. Of course, it wasn't called ADHD then. It was called hyperkinesis and then ADD, and we could go through that whole history. We do know that the first 10 years of life are the risk period for neurodevelopmental conditions. Boys' brains develop slower than girls. We're not going to spend a whole lecture on that. So it's little wonder that in the most recent reviews, it's about 3 to 1 for kids, boy to girl, for ASDs. Not 5 or 6 to 1 the way people had learned even a decade ago. And for ADHD, it's about 2.3 or 4 or 5 to 1 across international samples that are representative. So there is something about male brains that is slower to develop, is particularly susceptible to conditions that have social or self-regulatory problems as their basis, but it's nothing like the biases that we've seen in the past, especially out of clinical samples. Number 8, we know about comorbidity, co-occurring conditions. And so along the same lines, If a girl came to the pediatrician's or clinician's office, well, it must be the anxiety. It must be the conduct problems. It must be the learning problems. It couldn't be the ADHD because girls don't get ADHD. So again, the self-fulfilling prophecy has perpetuated. Number 7, what did we call this condition or set of dimensions for a long time? Minimal brain damage or minimal brain dysfunction. The immaturity syndrome back in the 50s. Hyperkinesis, hyperactivity. Finally, ADD and ADHD, the world's worst acronym, because you have attention deficit hyperactivity disorder, but you might not have hyperactivity or inattention. So I think we could clarify things. And relatedly, number 6, how did you get a research grant back in the day to study hyperkinetic kids or kids with ADHD? Use the Conners short form, the hyperkinesis index. How did the hyperkinesis index get formed? With the original Conners scales that are now through many different revisions. He chose the 10 highest loading items on a sort of overall hyperactivity attention problem scale, which also, and then cross-tab those with the 10 items that were most responsive to stimulant medications. So the HI, the hyperkinesis index, has how many items pertinent to inattention? 2. And what are the other items? Restless in the squirmy sense, restless always up on the go, acts as if driven by a motor, et cetera, clearly biasing toward male diagnosis because we didn't think there was an inattentive variant of ADHD, and the rating scale we used in all government-funded research ignored those items. Number 5, if you go into classrooms, as some both American and European scholars have done, and you have objective observers behind the mirror or on the side, coding specific behaviors. Boys are, in general, more hyperactive and impulsive than girls, but per the observers, they're pretty equal in terms of inattentive off-task behaviors. But if you ask the same teachers teaching those same kids when they're observed, the teachers say boys are higher in both. So the very people we use as the backbone of ADHD assessments, teachers, have a kind of implicit bias, if you will, that boys are both more hyperactive and impulsive and more inattentive. So another reason for the low identification. And Loyo Carbonneau in the Journal of Attention Disorders published a nice meta-analysis of this a couple of years back. Okay, we're getting down. Number 4, DSM-4 said you can't get a diagnosis of ADHD unless the symptoms have been in multiple situations and impairing since before 7. So basically, before first grade, before second grade. DSM-5 said, no, we were only kidding, middle school. So you have to have had those impairing symptoms before the age of 12, based on absolutely no empirical evidence. But it was thought to be maybe damaging to girls getting a proper diagnosis. But what about the many, many girls in their teens and young women and even older, middle-aged women out there who may have had underlying symptoms, especially of inattention, but they didn't get noticed. They weren't kind of emancipated from the woodworks until high school, college, post-secondary education, close relationship jobs, etc. Down to number 3, and relatedly, a lot of research. Sue Young over in the UK has gotten big consortia of investigators studying ADHD in the UK and Europe and put together some really good white papers on this. What do girls tend to do? We don't want to gender stereotype overly, but in grade school, we got to get good grades. Guys don't care as much, and we've got to be social and please our parents. And so, with a lot of parental compensation and often IEPs or teacher support, girls are struggling. If you look back, it's like the rings of a redwood tree, at the histories of girls who don't get diagnosed till later. What do you see in the report cards? If only she had tried harder. Doesn't seem to be very organized. If we could have only found the... And so there were struggles all along, but they were coped with. They were compensated for. And then, age of 12 or so, middle school, puberty, average age now below 12 in the United States, and with the subsequent challenges of high school and adult life, it's not an accident that people with ADHD, especially women, are being discovered late. Now, there was the big set of articles a few years ago by Arthur Kay and Moffat and Caspi and others saying that, you know, if you go to epi studies, you find people who wake up one day at 25 or 30 or 50 with ADHD. And we talked about that with our postdoctoral meeting at lunch today. If you come into my office and you say at age 47.2, I suddenly yesterday realized I have ADHD and have the symptoms, what are the two questions I ask you? What drugs have you been taking, and or what was the source of your recent head injury? Because you don't wake up one day with ADHD, but you might have, as a girl and young women, struggled and coped and compensated and been anxious and perfectionistic, and now the floodgates open. Number two, what do women go through? And this is somewhat defying what I said with slide 9. Puberty, childbirth, perimenopause, menopause. There are cycles of both biological changes and psychosocial duties and responsibilities that are different from those of guys and men, and each of those presents unique challenges for dealing with the underlying executive problems of ADHD. And I put a note here in the bottom. I've been searching for, my last book was Straight Talk About Girls with ADHD, trying to start a new one on women with ADHD. There is so little research on LGBTQI people with ADHD. It's kind of appalling. And there's case studies, et cetera, but that's a needed area of research. And so the number one reason, it's not really a reason, it's an extrapolation. Maybe people argue we should diagnose girls on the basis of girls' norms and guys on the basis of guys' norms, not girls on the basis of mixed gender norms. Because if we diagnose girls on the basis of girl norms for parent or teacher rating scales, more girls would get diagnosed. But let's think about it. Should we, now in every nation on earth except maybe a few matrilineal societies, the prevalence of major depression is 2 to 2.5 to 1 female to male. So I could make the argument that, well, we should then, depression's pretty tough in males too, we should base guys on the Beck Depression Inventory or whatever on the basis of male norms. And then that would equate. But is that really true? Or maybe guys show depression by drinking or stealing or fighting. Well, I think there's problems in the assumption that every condition we know has equal incidence and prevalence across sex and gender, across ethnicity, across nationalities, et cetera. So we want to be really careful before we automatically correct up that as many girls as boys get diagnosed through same-sex norms to see if girls diagnosed on the basis of such norms are as impaired as boys. So that's our top 10 list. I'm going to make a plug for the field that I've been very committed to for a long time, developmental psychopathology, which is based on principles coming from systems theory and evolutionary biology and embryology, that the whole is greater than the sum of its parts, and unless you study longitudinally many processes, psychological and biological, and unless you look at both normal, normative, neurotypical, and atypical samples, and you go, if you can, from genes all the way to national policy, and you look for both homotypic, the straight-up continuity, or heterotypic continuity, the more developmentally interesting form, and unless you consider that under equifinality, multiple roads lead to Rome. There's many different causal pathways for ASDs and ADHD and bipolar disorder, and multifinality, that the same risk factor may eventuate in very different outcomes depending on other psychobiological risks, depending on context, depending on treatment, et cetera, and that context and culture are essential for exacerbating or diminishing underlying vulnerabilities, then you're stuck with the DSM, which is a bunch of categories seemingly essentialist and different from each other, even though they may have, there may be comorbidities. And the developmental perspective, I hope you'll look for it. It's a little bit of a Where's Waldo. Some of these things I've just talked about will appear in the rest of the talk. So again, who are the most aggressive humans on our planet? 1.5 to 2-year-old boys. Just count the behaviors. So it's kind of right. And tantrums are a good example of that. Do tantrums at age 2 predict tantrums at 8 and 15 and 25? Not so well, but excessive tantruming at 1 and 2 may predict other forms of, quote, antisocial behavior that are shaped by development and context. So we're talking about a heterotypic continuity, a continuity of underlying process that may look phenotypically different across the ages. And stay tuned, because I'm going to have a lot to say about that in girls with ADHD. Some of you have heard of the gender paradox. It's not talked about. About 20 years ago, the literature was a hot topic. The biological sex or gender, and I'm using the terms interchangeably here. With the lower prevalence of a condition, A is going to have more severe manifestations of that condition, and B, there's a couple of reasons why that might be true. The polygenetic multiple threshold model. The lower prevalence sex, girls with ASDs, must have a higher genetic load or difficult pre- and perinatal experiences to lift them above the threshold. Or B, the constitutional variability model is kind of interesting. It's not discussed as much. I just said guys, boys are more susceptible to neurodevelopmental conditions. Not just ASD, ADHD, Tourette, some forms of learning disorders. Boys under this model are slower to develop their brains and self-regulated behavior. Therefore, we're going to see a lot more subclinical or subthreshold features in boys. But if a girl at the same time shows excessive ASD symptoms or ADHD symptoms, she must really have a neural, quote, defect. And I use the term advisedly, which is certainly not in keeping with neurodiversity. There must be something really wrong for a girl to have it, because boys are going to have more of these sort of bell curve of problems naturally because of the way the male brain is shaped. Fascinating topic, not enough good data with big enough and representative samples to prove either causal factor very much, but we'll come back to it. So, across the world, and we can thank Guilherme Polanczyk, the brilliant Brazilian epidemiologist, who's done meta-analytic, meta-reviews of the world's literature on the prevalence of ADHD, and around the world, in kids about 5 or 6 to 17, 18, the prevalence of ADHD is about 5 to 6 to 7%. What are the two exceptions? The United States and Israel, which today have double the rates of diagnosis. And I don't think there are major genetic differences. There has to be cultural factors, school-related factors, which I've talked and written about, we can talk about later. And across the world, there's a remarkably similar 2.2, 2.35, 2.5 to 1 ratio of boys to girls. So we may be approaching the asymptote of what's the problem here? These are all rates of diagnosed prevalence. We know the true prevalence of cancer because we've got biomarkers. It's hard to know the true prevalence of behavioral or neurodevelopmental condition. Even though the research is growing, we don't have the definitive biomarkers. Girls are more likely than boys to show up with the exclusively inattentive, what they call presentation in DSM-5. Boys are more likely to have greater levels of hyperactivity and impulsivity, and therefore get diagnosed with the combined presentation, both inattention and hyperactivity and impulsivity. And we know from big swaths of worldwide literature that kids with ADHD have a lot of long-term impairments, and girls are no exception. Early study back by James and Taylor in 1990 over in London. Girls with ADHD, or they called it hyperkinetic syndrome over in the UK back then, tended to have more language and IQ deficits than boys. Maybe that's because of the polygenetic multiple threshold model. It took more genetic oomph, and therefore they're going to have more associated symptoms. But again, the jury's out as to those underlying theoretical models. So I'm going to talk briefly about the Mass General study, and then a lot more about our Berkeley longitudinal study, to not so much focus on boys versus girls, men versus women, but about what developmental trajectories of ADHD look like in carefully diagnosed girls as they progress into and through, at least our recent sample is now in their mid to late 30s. So the Mass General studies, led by Joe Biederman, who passed away just a few months ago, got, at slightly different times, but with very similar ascertainment procedures, 140 boys with ADHD, 140 neurotypical matched comparisons, 6 to 17. So a lot of them are adolescents in the first place. 140 girls with ADHD, 130 didn't quite as get many comparisons, and followed, did a lot of genetic work, did a lot of behavioral phenotyping, and followed both samples up for 10 years. Pretty much a white middle-class sample, not exclusively. They excluded the lowest SES because it was people often in Harvard Community Mental Health, et cetera, not fully representative, but the girls with ADHD, now between 16 and their mid-20s, had much higher rates of life impairment, neuropsychological deficits, conduct and antisocial problems, substance use problems, anxiety and depression related to their comparison neurotypical girl sample, and similar rates to the boys with ADHD, who again were elevated compared to the male neurotypical sample. The one exception was that when girls with ADHD showed oppositional defiant or conduct disorder, it wasn't until later in development, not till the teen years, which is sort of a general trend. Don't have to have ADHD to show that in many female samples. So this was the first documentation that ADHD can really exist in a pretty large, well-documented sample of girls, blind diagnoses, really good experimental procedures. And it led my team and me in 1994, 29 years ago, to write a grant to the NIMH to say, could we take and this was before the Biederman studies had been published, they were just doing their initial work too, can we use the same summer camp methodology to look at peer relationships and neuropsychological performance and parent-child interactions for girls with ADHD, as we've done for many years, as with boys? And as often happens, NIMH said, you really think that's a good idea? You better revise this. And so, under a lot of revision, we resubmitted the grant, and back then, you got your scores via a fax machine before the pink sheets would come in. And we learned then that we got, our percentile rank was 0.01%. It was the top funded grant at NIMH that year. So I thought, maybe we're on to something. And then, good things happen, and then the next thing happens is, can we recruit a sample? So remember voicemail? So we put out advertising. I talked to 1 million pediatricians groups and talked to schools and school districts. And the first day we put out the call, the voicemail ran out by noon. And we ended up screening well over 1,000 girls to get, in the summer of 97 and 98, 99, girls with, and then we put them through the ringer of a multi-gated assessment, girls with classically defined ADHD, sex-neutral norms, and a neurotypical sample matched on ethnicity and neighborhood and age. I had an intuition. Now, you never want to go with intuitions too much in science, but in the spring of 97, we brought the first group of families in to orient them to the summer camp program their girls would be attending. There's a mixture of parents of girls with ADHD and neurotypical girls. And I remember thinking, should I say this or not? But I said, welcome to UC Berkeley. Our summer camp will be held at a local school. We're going to go through a lot of procedures. But I want to tell you something, families. We aim to study your daughters for the rest of their lives. And I thought, like a second later, don't like Homer, no. We only get grants 5 years at a time. What if we can't do that? But interestingly, after the 3 different camps with 3 different subsamples, and as we're writing our next grant, seeing what we published, what we found, families would call us and say, hey, what about that lifetime study of my daughter? Are you guys going to do that? So it set an expectation. And I'll show you in a minute the slide. Over the years, 5 years, 10 years, 16 years, now 25 years later, we've had retention rates of our sample of between 92 and 96%. We have been accused in blinded review from some journal articles that we have lied because no one gets those retention rates in studies. And we said, you want to bet? Do you know what it took? Making that pledge to families, writing reports on every girl. They had a free 5-6 week summer camp program, advocating, not crossing the line into being clinicians, but it really takes a lot to make a longitudinal study work. We found a lot of stuff. In July of 2002, we published our first paper on the baseline girls, 1st through 6th grade, 6 through 12 years of age, on 1 million outcomes, Bonferroni corrected. We were very self-critical, and the girls with ADHD had a lot of impairments in a lot of domains. And then we were and the point I was going to make is when we published that in the first week of July 2002, that day we doubled the world's literature on girls with ADHD, which is no great credit to us. It just shows how awful the field had been before then and simply not recognizing it. And then we started to write our follow-up grants. So, sociologist colleagues of mine who do national surveys will tell me, you know, if you want to measure change, don't change the measure, because then you've got a confound, which is an interesting proposition. You do want to, so in the national stigma studies that my colleague Bernice Pesco-Salido, distinguished professor at Indiana, runs, they have kept the same vignettes about mental illness since 1955 and the same social distance questions. So you can really track changes. But those are all adult studies. What about kids? Unless you bring in some new developmentally sensitive measures, you're going to be lost. And you got to, it's like the brain, you got to prune a little bit so that they don't, refuse to do all the work you asked them at follow-ups. And here's just the graphic of our first 4. We're still in wave 5, where all the women are in their 30s. We had to do it via Zoom because we started it during the pandemic. And there's a lot of good things about Zoom, but running a long-term follow-up study via Zoom isn't a great way to do it, but what are you going to do? And so these are the 4 waves we'll be talking about from now on. One of the things we did at our 3rd wave, which you just saw, the average age is 19 to 20. Emerging adulthood, as it's now called, thanks to Burnett. We added measures of self-harm, which, for the sort of sake of argument, I'll divide into 2 subcategories. One is suicidal behavior. There's an intent to end your life, and you can have intense ideation or actually attempt, and in some cases, complete. And the other big subcategory is non-suicidal self-injurious behavior. It used to be called parasuicide. It's always mistaken for or confounded with by borderline personality disorder, which is a feature, but it's not as simple as that. Where the goal is not to end one's life, but to deal with really bad psychological pain. Something's going on in the family, I feel terrible about myself, often don't have words to express it, a kind of alexithymia if you want to think of it that way. But if I see the cut and the blood oozing, or feel literally the burn, or the bruises on my head from knocking my head against a radiator. I mean, this is gruesome stuff. Maybe temporarily the psychological pain goes away. And it might, but what happens? It comes back again, fuller force, and you get a self-fulfilling prophecy. For some of the slides I'm going to show you now, I'm going to show outcomes for NSSI, moderate to severe cutting, burning, self-mutilation, versus attempted suicide. But don't think they're totally separate. In fact, meta-analyses show that probably the single biggest predictor of suicide attempts in one's 20s is a history of NSSI in one's teens. And it's become epidemic, as we'll talk about in high school girls before and now during the pandemic. What's the average rate, age of onset of serious cutting and burning these days? 12 and a half. Earlier and earlier. So some of the preventive interventions we want to do are with preteen girls before they've even shown signs, and then you write a grant and the NIH says, well, but it's too early, they don't show signs yet. And we say, well, that's called prevention. So a lot of struggle to get at this. To highlight, we published this just over 10 years ago at our Wave 3 assessments with validated measures. So go back 10 years. Some of the girls came into the program with a diagnosis of the combined then type DSM-4, combined type of ADHD. Some with the inattentive, and then we had our neurotypicals. 23% of the girls with childhood combined ADHD had made a serious suicide attempt. 8% of the inattentive and 6% of the neurotypicals. At that time, the 6% was exactly at national norms. This wasn't some Northern California skew. And in terms of another measure of the ways in which you might injure yourself without the intent to die, what forms are they, and a seriousness scale, moderate to severe, not hair twirling, not cuticle picking, but cutting, burning, other forms of self-mutilation. 51% of the combined childhood diagnosed girls were engaged in moderate to severe NSSI, a little over a quarter of the early inattentive, and 19% of our comparisons. 19% national average, which has now climbed well into the 20s in the last 10 years. So it's what the Surgeon General says, what CDC says, the mental health crisis among youth is real. It's on us. But what does ADHD have to do with it? Because this was our question. So these we thought were important findings, got a lot of press when we published that in Journal of Consulting and Clinical in 2012. But what does a longitudinal research team do? Look for mediational processes that might explain, that might be intermediate temporally between the baseline predictors and the outcome of interest. So I'm going to show you slides. These will test your working memory a little bit, but don't worry, I'll go back. The setup is the same for the next few slides. Did the girls have ADHD or not back in childhood at our summer camps? And we could do it categorically, you could do it on severities. It doesn't matter, the results are the same every time. And here the outcome, 10 years later, is the severity ranking of NSSI. And we had a bunch on our second wave when the girls were about 14 to 15, middle school, high school, a bunch of processes about peers and about neuropsychology and about symptoms and comorbidities. The only two significant mediators of the early ADHD to NSSI link were first performance on the good old cancel underline test, a classic neuropsych test of response disinhibition, and the girls and the parents and the teachers' reports put together of her externalizing symptoms. So take a look. It's the same slide. No, it isn't. It is, except we're now going to suicide attempts. The only significant adolescent mediator of attempted suicide was the girls and the teachers and the parents amalgamated depression, anxiety, and social withdrawal, internalizing symptoms. So it gives us a hint that there may be some different mechanisms. Response disinhibition, externalizing symptoms preferentially predicting NSSI, internalizing symptoms, again, multi-informant, preferentially predicting attempted suicide, where the intent was to die. And this was Erica Swanson's doctoral dissertation published in the Journal of Child Psychology and Psychiatry. Jocelyn Mesa, who graduated from the lab subsequently, is now a professor at UCLA, was very interested in the same model, but what about adolescent peer relationships? So here, the predictor over on the left is commission errors on the Conners Continuous Performance Test. It could have been ADHD symptoms. It could have been ADHD diagnoses. You know, it doesn't matter. Predicting NSSI severity. What was the sole peer-related variable that significantly mediated that predictive association? The girls' report in middle school or high school of how much and to what extent other girls physically or verbally bullied her, victimized her. But again, now we've changed the outcome to attempted suicide. The only significant partial mediator was the teacher's report on Tom Deshawn's social preference scale, the teacher's report as to what percentage of her classmates actively rejected her. So it's actually the opposite of social preference. It's negatively weighted. So again, just as you're looking for hints here, it looks like self-perceptions of being victimized and bullied are a strong mediator of NSSI. but that low social preference, as reported by a third party, a teacher, being kind of kicked out of the peer group, is a significant mediator for attempted suicide. I know these are kind of, clinically gruesome outcomes, but this is what we're studying. And again, the underlying question is, what would make an inattentive, poorly self-regulated, impulsive girl, mainly showing up in a classroom in grade school, turn into an adolescent or young adult actively interested in injuring herself to escape pain or ending her life? So that's a kind of heterotypic continuity I think we really need to focus on in female samples. So what about trauma? Maya Gundelman, let's see, that was Jocelyn Mazen. Maya Gundelman, now a neuropsychologist in the Bay Area, for her master's thesis, had blind coders, this took a long time, 1.5 years, go through all the girls, neurotypical and ADHD's charts, and blinded to who had ADHD and not. Was there clear evidence of physical abuse or sexual abuse or neglect? And then we put those together because it was relatively small in each. Number one, not surprisingly, the girls with ADHD were more likely to have received early maltreatment. But much more important, number two, within the ADHD sample, and these groups are equated on ADHD symptoms. If you were a girl in our summer program with early ADHD, and you had received either physical abuse or sexual abuse or neglect or some combination, the odds were 0.34 that you'd attempted your life. And if you were the same level of ADHD, but without that maltreatment, it was 1 in 7, 14%. So now this is a small sample, but to us it's really interesting because it replicates almost precisely, and again, with a small sample, I won't overstate it, what happens with bipolar disorder. What happens in bipolar disorder with its heritability of well over 0.8 to 8.5? Highly genetic in its liability. If you have bipolar disorder and you've been physically or sexually abused as a kid, your suicide risk, which is already astronomical for bipolar disorder anyway, goes up by 50%. What's the heritability of ADHD? We talked about it at lunch too, 0.78 to 0.82. The risk for dysregulated behaviors pertinent to ADHD is largely genetic. But if you've also experienced maltreatment, now your risk of attempted suicide more than doubles. It's not genes and biology, it's not early experience and trauma, it's both together that I think is the most pertinent clinical picture. Maya also found in another study, which will come up in just a second, that the girls with ADHD by wave 3 reported 3 times more intimate partner violence, sexual violence, than the neurotypicals. So, in giving talks to community agencies and things like that, I'm often asked to discuss, well, how do you know if a young kid has ADHD or they've been maltreated and traumatized? Very long story. The only thing I'll leave you with now, in interest of time, is it's possible for there to be both. The risk factors for having ADHD as a kid, young mother, impulsive mother, maybe one who drank, et cetera, may be the same risk factors for being traumatized. And so you get 1 + 1 equaling 5 or so. It's synergies rather than either-ors again. A couple of other factoids. By our 4th wave, when the young women are now between 25 and 30, the comparison group, 10.5% had had 1 or more unplanned pregnancies. The ADHD group, about 43 to 44%. You don't need a significance test to know that that's a big difference, right? As the years went on, we didn't find any differences in rates of high school graduation between our ADHD and neurotypical sample. Everybody said, of course, you got. Wait till you get that diploma. And as the families told us qualitatively, we picked her up on our shoulders and dragged her across the finish line. How many community colleges, how many multiple schools, how many flunk outs, along with difficult vocational experiences. The legacy of ADHD in girls is, during this period of early adulthood, emerging adulthood, the launch period is taking a lot longer. I love the Owens and Hinshaw study, but we don't have time to talk about it. Our own Megan Miller, your vice chair here for psychology, did many studies as she was in grad school She was out here learning a lot about autism spectrum, and at Berkeley learning a lot about ADHD, and now she's the complete package you see in front of you every day. And so this was this your dissertation study or related to it? I can't remember. You published so much, I can't remember. But Megan was interested in knowing what the executive function, and we did a lot of neuropsych testing. Before the summer camps, we could pull girls out for periods, when everybody else was, doing some other activity. It wasn't necessary to be observed. So, working memory back in childhood and on the Ray Osterreich, a kind of global measure of poor planning and executive functioning, were potent predictors of low academic skills, poor occupational skills at our third wave. But this was especially so for the girls with ADHD, where the low working memory score as a kid predicted poor reading later on, and the low Ray, low planning, and overall executive functioning score was especially predictive of something like school suspensions. So we've been interested for a long time in what about cognition, what about cold versus hot cognition, what about executive dysfunction, which is really pertinent for girls with ADHD who may not be as frankly annoying or bothersome or externalizing as many boys. What are the predictors of long-term outcome? And we know that, and this was another dissertation from Chanel Gordon, who's now at Boys Town as a career researcher. The girls with ADHD were way behind in executive functions when they were girls, and we repeated a subset of the battery. If you want to measure change, don't change the measure. The same tests. And the girls with ADHD improved, but the comparison girls really improved on these non-norm tests. And the real academic bugaboo for girls with ADHD, at least in our sample, is by the time they're in their fourth wave, their scores are in the 18th percentile in math on the way at math achievement tests. It's the stereotyped area that girls aren't supposed to do well, even though we know from meta-analyses that girls do just as well in boys in high school math if they take math classes. And it involves executive function the further along you get in math. And executive and academic problems in adolescence and early adulthood we're looking toward as mediators of some of the other negative life outcomes. For example, one of the mediators of this extraordinarily high rate, threefold greater rate of intimate peer violence inflicted against girls with ADHD when they're young women or during adolescence, is partially mediated by their middle school and early high school grades and reading and math scores. So it's great to help someone boost their attention through a medication. It's great to reduce impulsive behavior through a contingency. Medications are quick at reducing symptoms like that, much more so than compared to behavioral interventions. But if you want to improve academics and family interchanges and peer relationships and comorbid externalizing and internalizing symptoms, it really takes the combination, which is another lunch topic we discussed. The combination of well-delivered medicine, behavioral family therapy, school consultation, and for adolescents and adults, CBT, anger management, organizational skills. It's clear in the literature it's the combination that brings you much closer to the normal range than either modality alone. Jocelyn Mesa, who's a professor at UCLA now, we wanted to look early on as well, not just the adolescent mediators, but what could we have learned back when they were in grade school that might have helped predict NSSI, suicidal ideation, or suicide attempts. And some of these aren't too surprising. The severity of your ADHD, the externalizing problems, especially for NSSI, more than the girl's report of her negative interchanges with mom, it was her report of negative interchanges with dad that were the main predictor of NSSI. So father-daughter relationships can be really troubled for girls with ADHD as well. Poor executive function deficits, working memory, global executive functioning, as we've been talking about. Low self-esteem, the good old self-esteem indicators, the Matthews scale, and then later on the Rosenberg. For a long time, people were thinking that kids with ADHD, mainly boys, they had sort of overinflated self-esteem. They thought they were doing better than they were. But for girls with ADHD, we see no evidence of that, and low self-esteem is an extremely potent predictor of later internalizing symptoms, suicidality, and self-harm. And not surprisingly, at Way Forward, when we gave the ACEs interview, which is to report back on your first 18 years of life, the more adverse childhood experiences you've had was a potent predictor of all three forms of self-harm. Our studies have, compared to most of the male literature, shown lower rates of substance abuse, except for tobacco, and delinquency than in typical boy samples. And as I mentioned before, they graduated from high school at relatively similar rates, but barely. But the self-harm, which, again, we've now had 2 completed suicides, and they were only from girls in the ADHD combined type, growing, back when they were girls. We know that self-harm can be time-limited, especially NSSI, but the range of negative life events that girls with ADHD experience, and this wasn't a clinical trial. Some were taking meds, some not. Some were in other forms of treatment, is alarming and shows why, and now the European and South American nations are publishing their own data, and these are not longitudinal, these are epi-studies in adulthood. The relative risk of suicide attempt for males with ADHD is about 1.5 to 1, and for females about 2 to 1. So it's not just this Berkeley sample, very carefully studied with a small n. Around the world, we're finding that ADHD, and of course all the many things associated with it, are pretty potent predictors of very serious self-harm. So we talked about this. Boys have it tough early in terms of neurodevelopment, but let's not forget that by puberty and middle school, girls shoot ahead of boys in terms of anxiety, depression, self-harm, binge eating, and other symptoms like that. I wrote about this in a book called The Triple Bind 14 years ago. Every prediction in that book, which I thought was overstated at the time, although I didn't tell my publisher that, has come true. The rates of girls, adolescent, young adult girls' mental health problems are as bad as the headlines you're reading. What about treatment? And this would be a whole other lecture, so just a few tidbits here. There isn't much systematic research on boys versus girls, males versus females, men versus women, differential response to treatment, because there hasn't been much research on girls and women with ADHD. That there has, albeit statistical power could be a confound here, don't find many sex differences. In the most recent large review by Koch et al. In Public Library of Science 1, published 2.5 years ago, over the world's literature, girls and women seem to have more adverse reactions to stimulants than boys and men, and tend to respond better preferentially to the non-stimulants, the alpha-2s and the strateras of the world and the antihypertensives, which may be a treatment option for girls and women that is underused, at least a lot in our country. And based on work that I've done in conjunction with Linda Pfeiffer at UCSF, Sue Young and her colleagues in the UK, if social issues are such a priority for girls with ADHD, maybe we need to prioritize group interventions more, to unmask the masking and the compensation and coping, and talk about, not just to commiserate, the difficult life experiences that, in combination with evidence-based treatments, may get girls out of this heterotypically continuous rut. So we're going to close, after a little water, with the topic of stigma, which of course could spend a whole other hour or 3 on, and focusing on stigma related to ADHD and especially females with ADHD. So stigma is an ugly word. Just say it to yourself, stigma, the fricatives stick in your throat. And what is stigma literally? It's the burn marks or brands placed on the skins of individuals, imbued into their skins and tissues by a more powerful group that thinks that the group maligned is bad in some ways. In ancient Greece, how would you know at the agora in Athens that your fellow shopper hadn't fought for Sparta or was a former slave. Well, you knew because they were branded. Physical stigma. There's not as much physical stigma in the current era, although if you were in a concentration camp in Germany and Poland, you had a tattoo or a brand on your wrist. Many nations, over 30 by last count, physically branded, stigmatized HIV-positive individuals in the 80s. Stay away. Contagious. But most stigma today is inferred because we know about you and your kind or your group or those with another mental condition like yours. We don't have to physically brand you because we don't really have to. So, without getting ramped up into a whole talk on stigma, many groups receive stigma. In current data from US population surveys, which groups receive more stigma than other groups? Do you have a mental illness or neurodevelopmental disorder? Do you abuse drugs and or are you homeless? That's the bottom three. And it's been pervasive. Stay tuned. Stay awake for 5 more minutes because there's some encouraging data coming up, although not entirely so. And both from evolutionary psychology and social psychology, we're humans, we're very social, but we can't be overly social or we'll get exploited. So we all have stereotypes, us versus them. I'm a very progressive Berkeley professor. I've never stereotyped anybody except Stanford students and professors are arch rivals because they wear red and they're in an elite private school, right? Well, was I stereotyping? Everything I said is true, but you heard my tone of voice. I wasn't just prejudicial, or I wasn't just stereotypic, I was prejudicial. I didn't like those Stanford people. And no Stanford student's going to take my course for extra credit. Discrimination. And this is a trivial, funny example maybe, but what has discrimination meant for people with autism and intellectual disability and ADHD and bipolar disorder and PTSD and schizophrenia over the decades? Total exclusion from society and genocide. Who was in the concentration camps? People with intellectual disabilities and mental disorders, and gay and lesbian people, and Roma, as well as Jewish individuals. So this is the book I wrote on the topic. God, 2007 needs a second edition. Any volunteers? No, never mind. I've got too much on my plate. But this was a review of the kind of world's literature on the stigma related to mental illness that I spent a sabbatical working on just to sort of catch up with prejudice and stigma racially, religiously, and how it pertained to mental illness. I did choose for the cover art a painting, a middle of a painting of a triptych by Hieronymus Bosch, the phantasmagoric Dutch-Flemish painter. And the name of this painting, a couple of you in the audience have seen the slide before, is The Extraction of the Stone of Madness. Because what in 1496 did people in Holland think caused mental illness? A stone in your head. So the surgeon, but the surgeon's wearing a wizard hat. What? Bosch is toying with us already. The surgeon wizard is removing the stone. The priest with the chalice is giving a blessing. This poor non-anesthetized patient is saying, what? Looking at us, what's going on here? But if you can see from how far back you are in the room, it looks like a couple little white tufts are emerging from the patient's skull, not a rock. What was the name of mental illness in Holland in 1496? You were called a tulip head. Tulips, the main source of industry then and even now in the Netherlands. So Bosch, 500 plus years ago, was saying, if you remove the tulipness, the label, does that emancipate the person and take away the stigma? Or is the tulipness part of the disease that can be conquered and cured? Very modern in the wake of neurodiversity these days, and is ADHD a hidden gift or a deficit, et cetera, et cetera. So, if society stigmatizes a group, one of the many I showed on that previous slide, it's likely but not inevitable that people in that group will come to internalize the stigma. They knew back in the day the campfire stories. Today, all you have to do is go on Twitter or social media. You know what the stereotypes are. And if you internalize them separate from your own anxiety or depression, self or internalized stigma keeps people away from treatment or helps them to drop out earlier. So self-stigma is a big goal. courtesy stigma. Goffman, who wrote the book, 1963, Stigma, Notes on the Development of a Spoiled Identity, sociologist who ended his career at Berkeley. I wish I'd met him. He passed away before I got to Berkeley. Qualitative sociologist who wrote the book on stigma, anticipating all other research in the last 50 years. Goffman said, sardonically in one chapter, if society bothers to stigmatize a group or an individual in a group, it's only common courtesy to stigmatize anybody associated with that person, like their family. And what about families? It's the double whammy, isn't it? The refrigerator parent view of the etiology of autism, the schizophrenic mother view of the etiology of schizophrenia, the totally permissive parent view of the cause of most ADHD. So not only you're close to, but you actually caused it. Who else receives courtesy stigma? I do. I'm a clinical psychologist. I work with kids who don't learn well and kids who are very dysregulated. Oh, and by the way, I had severe mental illness in my family all growing up, although the doctor said never to talk about it, so I didn't know why my dad was gone half of my childhood. Courtesy stigma is pernicious, and this is a study now almost 20 years old. Otto Wahl, W-A-H-L, did a national survey of, through NAMI, adults with bipolar disorder or severe depression or schizophrenia. And then he flew around the country, interviewed 200 of them qualitatively. What was the number 1 or 2 or 3 cause of stigma as reported by these adult psychiatric patients, if you will? They're therapists. They're providers. They never think I'll get a job. They never think I can complete school, all the way to the horrific acronym GOMER. You know GOMER? Get out of my emergency room. We only take people with real physical illnesses or illnesses here, not crazy people or people who put drugs in their bodies. So courtesy stigma is part of all of us. And again, with both extreme and the more moderated views of neurodiversity lately, I'm sure you're all talking about the way my lab group talks about almost every other week now. What does neurodiversity mean for ADHD, autism spectrum disorders? What does it mean for bipolar disorder? Who's on a spectrum and who's not? I mean, in grad school, good old UCLA, but every place was behind the time. You had bipolar disorder or you didn't. You had autism or you didn't. And of course, they're called autism spectrum disorders, and the bipolar spectrum, and the ADHD spectrum. So our views are getting challenged. Structural stigma, Mark Hatzenbuehler, who moved from Columbia to Harvard a couple of years ago, is really the expert on, especially for the mental health problems of sexual minoritized youth, the policies in that state, the anti-bullying policies, or the victimization laws that give some protections to people of sexual minority status, greatly influence cross-state differences in not only depression and anxiety, but also how well people respond to CBT or DBT. So if you're in a system that devalues you and doesn't give you protections, not only do you suffer mentally, but you don't do as well in an evidence-based treatment. So what does this have to do with it? So here's the book I wrote that Megan was kind enough to mention, Another Kind of Madness. That's my dad, a philosopher who had his first bipolar episode, misdiagnosed as schizophrenia for 45 years, down in Southern California. Me as a college freshman. About 2 months after he'd finally disclosed to me why he was gone for my sister's childhood and my childhood so much of the time, that he'd been in terrible mental hospitals, what they thought were schizophrenic episodes, and he was very psychotic. They were classic Cade-like mania episodes and depression episodes. But he couldn't tell my sister and me until I had just turned 18 before this picture was taken, because his lead doctor at Ohio State said, if your children ever learn of your mental illness from you or your wife, they'll be permanently destroyed. The family's never allowed to discuss the topic. That was the doctor's orders. It's so toxic, don't talk about it. So what do you do when you're in a family and things are bad, nobody talks about it? Well, there's 2 choices. I'm being terribly categorical. You can believe, A, the world's a terrible, random, cruel place, not a very healthy attribution, or B, it must be my fault. It probably isn't your fault, but at least you maintain a false sense of control. And that was my childhood and adolescence. And then Dad spoke up, and I went back and changed my major to psychology at college. Thought maybe I'd do something about lonely kids and families and neurodevelopment and psychosocial, and it made me, into the psychologist that I've become. Knowledge in America about mental illness has grown precipitously over the last 50, 60, 70 years. But attitudes, including social distance, how close would you like to be with someone with one or more different forms of mental illness, has not budged. And in fact, 3 times more people now, when they hear the term mental illness, think of aggression and violence than in 1955. Involuntary commitment laws, homelessness, all that. Until Bernice Pesco-Solido, my sociologist colleague at Indiana, published in JAMA Network Open just 15 months ago now, the first change with an effect size of 0.4, American adults now are much more accepting and willing to be close with someone with major depression. Why? Young people, well, if you look at the cross-sections, it's people under 30 who are driving that effect. But in the same study, stigma toward schizophrenia and substance abuse had gone up by a D of 0.2. So there's something, it's more okay to be depressed, but it's really not okay still to put stuff in your body that you shouldn't, or to be psychotic. So we've got a long way to go. So to close, why would there be stigma against ADHD? I mean, it's not as severe as bipolar disorder or schizophrenia, or in many cases PTSD, et cetera, et cetera. But therein maybe lies the rub. I didn't mention this, but because we didn't have time. If you go through working memory, and if you go through planning, and you go through response inhibition, all the kind of neuropsych cognitive control tests you could give, which one of them has the biggest effect size in differentiating ADHD from comparison populations? It's a trick question. None of them and all of them. The biggest effect size is intra-individual variability, trial to trial, across any of those tests. People with ADHD are consistently inconsistent. This may have to do with the default mode network, which we can begin to talk about. So what does most human observational power tell us about somebody who's inconsistent? They're not trying hard enough. Why did you do well in algebra, not so well in English? Why did you do well in practice all week, and then in the game, the winning goal buzzed by you because you were picking at a dandelion? When the attribution is to a condition that you can control, which obviously you can with ADHD, you're just lazy and unmotivated, not trying hard enough, the stigma can be strong. What about girls with ADHD? Well, you're not as socially adept as most other girls, and that's pretty important. And you're struggling with those paradoxically high and low grades at the same time. So girls and women with ADHD may be receiving double or triple stigma. And again, we could talk a long time about how to reduce stigma, but for my money, youth enforce the Americans with Disabilities Act, contact, evidence-based treatment. What reduced the stigma of HIV? The triple cocktail, the antiretrovirals in the early 90s. The stigma of against HIV plummeted because it's treatable. Now, is that true for autism spectrum? Do we treat it, or do we say it's a difference? What about ADHD? Isn't it really a hidden gift if you find the right job? I mean, these are the issues that are going to perplex us for a long time coming. Nonetheless, stigma does remain strong against ADHD, and especially girls and women. So, in sum, does ADHD exist in girls and women? Yes. What's the big problem among many big problems? What's the average length of time it takes for a kid with ADHD to get diagnosed today in the United States? 12 minutes in a pediatrician's office. No rating scales, no developmental interview, no trauma history, no nothing except the parents complain, and the pediatrician knows that he or she's got a prescription pad and it sounds like ADHD. The quick and dirty diagnoses can underdiagnose if a kid's not acting up in the waiting room, but overdiagnose because so many other things look like and mimic ADHD. in the evidence-based assessments we should be doing, focus on hyperverbalness rather than just hyperactivity. Remember that teachers may be reporting inattentive symptoms in girls. And as you get to know a girl and her family better, what about that coping and masking and compensation? If you can unmask some of that masking, you may get a truer picture as to whether ADHD is part of the diagnostic picture or not. And again, we talked about the masking, talked about heterotypic continuity, and I don't just say this as a sort of feel-good thing. What's the biggest lack in all assessments of kids with ADHD? Finding the kids' strengths. Those are going to be your reinforcers for the reward program you set up. They're going to be the things, maybe non-traditionally, that they do in middle school or high school and careers. And they may not be the complete package of, especially the kind of nice, sweet girl you expected to be raising, but if you look for and find those strengths, in addition to consistent contingencies, finding the right medication, coordinating with school, this is going to go a long way. Peer interactions, again, self-esteem should improve, but remember, some of you, nobody's as old as I am in this room, maybe a couple of you, remember California back in the 80s had the self-esteem law? That we had to boost self-esteem of every Californian kid? Oh, it was the law. But what happens when you falsely boost someone's self-esteem without a real skill base? It's BS. So it's a skills-based approach of finding strengths, reinforcing strengths, and especially for girls, given the high rates of unplanned pregnancy and sexual violence, sex education and advocacy is hardly ever discussed in the ADHD literature. So thanks to my lab and thanks to funders, and I don't have a big slide with everybody's picture, and thanks for the Mind Institute for inviting me here, and I'm glad to take some questions.
So it kind of seems like girls with ADHD kind of have possibly social genetic factors that can either mask or compensate some of the deficits at younger ages, and then it kind of has a blowback or delayed effect after school grade. Is there any factors that you saw that mitigated that like delayed response, and is there any positive social pressures or behaviors that could be implemented with boys with ADHD to help mitigate or compensate some of the
help mitigate what? The masking? Or I missed that?
Mitigate the deficits.
So don't get me wrong. In our summer camps and clinically and research-wise over time, we've seen a lot of girls who are just as active and ornery and take no prisoners as any boy with ADHD. They're out there. But more often than in boys, in fact, substantially more often than in boys, these are girls who primarily have executive dysfunction, primarily inattentive, maybe shy and anxious rather than oppositional and ornery, who really want to please and do well, but aren't quite sure how. And then the parents are, I'm going to digress for a minute. This new book of mine came out just last fall, Straight Talk About Girls with ADHD. I took till page 2 to bring in 2 concepts from dialectical behavior therapy, which isn't an evidence-based treatment for ADHD per se. But this is a book written to parents. I'm talking to you as a clinician and researcher, talking to you as parents. And on page 2 I say, so now you're grappling with this daughter that you're trying to get assessed for possibly ADHD, or maybe she's already been assessed. You need to radically accept your daughter. She's probably not the girl you expected. She's not sugar and spice. She's making every mealtime difficult. The teachers are on you all the time. You're not going to do anything that's going to truly change that temperament. And once you accept who she is, maybe then you'll be ready to, especially as you learn more in this book about biology and genes, and it's not just your fault, radically commit to treatment. Because these are kids who need extrinsic reward systems, much more than neurotypical kids. And they may need medications, and they may need accommodations in school. Now that's a whole other thing. Most school accommodations for kids with ADHD are counterproductive, like extra time on tests, which gives you extra time to do better and teaches you nothing evidence-based about learning better in the future. So radical acceptance and commitment, families owning, and again, with the heritability of above 0.8, 35 to 45% of biological parents of kids with ADHD will have ADHD themselves, whether diagnosed or not. To parent a kid with ADHD, you kind of have to be a super parent. Always organized. Never make a promise you don't keep. Always have that reward there. Punish without raising your voice. But what if you don't balance your checkbook and are sort of emotionally dysregulated yourself? And you've got a kid fighting fire with fire. So now that I've totally lost your question, it takes acceptance and commitment to change. It takes families getting good psychoeducation about what ADHD is and willingness to do a medication trial. You can often tell with stimulants within days or weeks, not month after month, if that agent and that dosage is working. What you're trying to do is turn the corner for a girl's makeup, if you will, her genetic vulnerability and some of her executive dysfunction, and finding those strengths will help you create maybe a different life from the one you've expected, but maybe one that can be really remarkable and productive.
So the women and the girls that you described in your presentation is exactly me. I am 42 years old, and I get very emotional, I'm sorry, to talk about this. I was just diagnosed last year,
Wow.
and I fought really hard for my diagnosis. I have people in my life that are very accepting of me. I'm in a great marriage. My husband accepts all of my quirks and all of my, strengths and all of my challenges. I have family members that accept me and friends that accept me. And when I got my diagnosis, like all the pieces came together and it explained a lot.
Yeah.
I went through this process of like relief. I went through the process of I went through relief. I went through like anger. I went through a period of mourning for all the struggles that I faced when I was in school.
Yep.
I fought really hard for my diagnosis because I was told I was a good student. I have my master's in social work, and you were talking about when you have someone with ADHD that lands in their dream job. I'm a school social worker now, so I'm able to offer support to students with ADHD, and I've actually been able to spot students, including girls, that have presented with symptoms that nobody else in the school caught except for me. And I'm like, she probably should be screened for ADHD. And sure enough, it's like, oh yeah, she meets the criteria because of the inattentiveness, right? That they're not hyperactive or whatever.
Right.
So thank you, like just hearing this, it's just like you're talking about me and my life. And, I feel like, I'm a representation of someone who's making it and made it, because people that have this diagnosis, women that have this diagnosis don't always end up in my situation. Right. The reason I'm here is because, of course, I'm just newly diagnosed, I'm wanting to learn more, but I also want to learn to support my students because, I work with students with ADHD, particularly girls, and their self-esteem is to the floor because of various reasons. People don't have the patience, parents don't have the patience, so they're hearing, this negativity at home, you're just lazy.
Or the parents think there's something wrong with the way they parented her, there's something wrong with her, and it's a vicious
There's
cycle.
so many reasons, and then at school, teachers are like, what's wrong with you, why are you not, go to the office, you're being distracted, or you're not, trying hard enough, or why don't you do anything, and they don't understand that, this little girl in the classroom, she's just struggling and internalizing all this, and really falling apart, even though she's just daydreaming or just very disconnected. And so I want to know, like, if you can tell me of books, of any resources that I can take back to my school to better support my students. I understand my experience is very personal too, but I don't, as you know, every person with ADHD is very different too. Yeah. And so I want to be able to learn how to support them. So if anything that you can say, like, hey, this is book you should read, this is a presentation you should listen to, I'm all ears because our students need a lot of support.
There's this guy named Hinshaw who wrote a book last fall called Straight Talk About Girls with ADHD, How to Help Your Daughter Thrive. Guilford Press, 2002. And it's written right to parents. But at the end, there's a lot of lists of resources about, for families and for schools, and about self-harm, and the websites and international, and that might be a place to start. I mean, there's a lot of attention finally being directed to girls and women with ADHD. And like a lot of stuff you read on the internet, you take with, not a grain, but a ton of salt. Medications are poisons, or every woman has ADHD, and it's just as equal as in men. And so, but at Shameless Self-Promotion, if you start there, you'll find a lot of resources. And I'm going to ask you one question, and thanks, bless you, and thank you for your disclosure to us. What do you think kept the diagnosis from emerging for so long?
I definitely, anxiety.
Anxiety.
I think that was like the fire under my butt that kept me doing things. I enjoyed challenges when it was interesting to me. And so I was very much perfectionistic. I had, perfectionistic tendencies.
So you coped and compensated.
And
you
masked,
did well.
and
You went for it with a new challenge. But then not everything in life is a fun challenge.
Oh, yeah.
Right?
Oh, yeah. And then, of course, but that all caught up to me a couple years ago, and I hit like burnout, and I didn't understand it. I mean, on top of COVID, and I'm a very busy girl.
Thanks for that, and this reflects thousands of stories going on right now in our country.
Yeah.
So thank you.
Yeah. So once the anxiety was treated, though, it made my ADHD symptoms worse because I didn't have that anxiety to keep me going. And so that's eventually how I ended up getting diagnosed. I'm like, well, it's probably anxiety. It's probably depression. Okay, well, I'll go to counseling. Right. And then it's like, hey, my symptoms are worse.
Well,
I think it's ADHD. And finally I had someone
listened. You need a
listened.
holistic assessment and a holistic treatment program.
So Dr. Miller here has a wonderful video on the Mind Institute website on girls and ADHD, a very nice evidence-based video.
Great.
That Patrick put on YouTube. The Mind Institute actually has a ADHD resources site where there's lots of resources and listed and so forth. So Steve, masterful talk as usual, and I want to thank you for all the decades of collaboration. But you didn't mention emotional dysregulation and irritability, and asking about that when we're evaluating people, particularly women. And we did find that higher rates of irritability in girls leads to greater rates of impulsivity later.
Yep.
So one, what do you think about looking at that on the rating scale specifically? And two, the relationship between that and stigma, perhaps, because when you're more irritable, that affects the people around you as well and going to have a negative feedback loop potentially.
Yep.
And I'm wondering about that in relationship to stigma.
So irritability is, it's an old term, but it's really had a big life in child clinical psychology and psychiatry for the last 15, 20 years. So what is irritability? A proneness to anger and eruption. You know what I mean. You can see the look on that person's face, or you can see the kind of slow building, or maybe not so building. And so back in the early 2000s, when it became, up until 1995, we knew that bipolar disorder didn't exist before 15 or 16 or 17. There was no such thing as child bipolar. And then the Mass General group, in addition to their ADHD work, they said, well, bipolar disorder exists in kids, but it's not episodic like adult bipolar. It's got high internalizing and externalizing and a lot of irritability. And so then a label came out of severe mood dysregulation, and was there really bipolar in kids, or does it? So back at NIH, Ellen Liebenluft and her colleagues started to systematically look at irritability in preschoolers, in grade schoolers, and in teens. Looking, and it's not just emotion dysregulation, it's this short trigger. This is a person who's ready to explode mildly or bigly. And it turns out that the majority of kids who had all of a sudden been quickly diagnosed with bipolar disorder really had irritability. Bipolar disorder does exist in some kids and early teens, but not zero, but not as much as people had thought. So irritability now is a construct that people are studying its heritability, and what are the social and contextual influences on it, and can you treat it? Because irritability appears in ADHD, autism spectrum, anxiety, depression, conduct disorder. It's a transdiagnostic thing. And I didn't mention it today because I already went over time and I had about 50 more slides I couldn't use. So, but often for girls, it's maybe they're not as overtly aggressive or externalizing as boys with ADHD, but they've internalized that they're not doing well. They've got that kind of temperamental proneness to quick reactions that can appear like bossiness to peers. I mean, back in our summer camp days, when we had only boys at the camps, we had some boys, and we do sociometrics, peers rating other peers confidentially. We had some boys at our camps who were actively disliked by 30 to 35% of their classmates. That's bad. Then we ran the girls' camps, and we had girls disliked by 75 to 80% of their classmates. Both girls with ADHD and neurotypical girls. Because she interrupts all the time. Well, maybe she interrupts all the time because she has poor working memory, and if she doesn't interrupt, she won't remember what she was going to say. Or maybe she's irritable and wants to get her point of view in. Or maybe she doesn't read facial cues very well. So these related emotional reactivity, which is a form of irritability, and emotion regulation, the big debate for the last 50 years in ADHD is, should that be part of the ADHD diagnosis, or is ADHD more of a neurocognitive thing, and the emotion dysregulation and the irritability are kind of side comorbid parts? And people still actively debate that today.
Related to the irritability, you didn't talk a lot about Tourette's and tics, and about a third, I think, in my experience of ADHD kids are on that spectrum too, particularly the ones that are irritable and really tantrumy.
Yep.
Oftentimes they develop tics and this emotional dysregulation, even more severe over time. And they can have a lot of OCD symptoms, of course, it's mental tics and social deficits, anxiety, et cetera. But I think that should be questioned anytime you're looking at kids with ADHD, because it's a different, subgroup.
So tics are, if you want to see tics, go into any first or second grade classroom and look at the boys. Barking, and it's many cases in boys it developmentally regulates over time. And then tics versus Tourette, chronic vocal and motor tics, which is, again, more prevalent in boys, like other neurodevelopmental conditions, than girls, but is under-recognized in girls, and it's confounded with OCD behaviors and with irritability. So we need to train primary care people to be looking for this stuff, because there are treatments that can work. I totally agree.
The UC Davis Mind Institute was founded in 1998 with a promise to reduce and prevent the disabilities that can be associated with autism and other neurodevelopmental conditions. Every day, our clinicians and researchers make progress on that promise. Our groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other conditions associated with disability are helping affected individuals achieve their fullest potential. Please visit our website or our social media platforms to find out more about current studies, upcoming events, and how you can help make a difference.